So good afternoon and a very warm welcome to this afternoon session at the National Thrombosis Week 21 virtual conference. My name is Jim Moore and I'm a GP and a GP with special interest in cardiology. And I'm currently the president of the Primary Care Cardiovascular Society, an organization representing healthcare practitioners and professionals working with patients with cardiovascular disease within primary care. And for those who may be interested, membership is free. And there are many membership benefits by joining our society online. So UK data I've seen recently suggests that the prescribing of warfarin continues to contribute significantly to the overall use of anticoagulants in the UK. And it's likely to continue to do so for the foreseeable future, even considering the likely shift to an increase in the use of direct oral anticoagulants following the recent publication of the NICE atrial fibrillation guideline. Therefore, this afternoon's session, Managing Patients on Warfarin, Practical Tips and Case Study, is very relevant moving forward. With three superb presentations this afternoon covering many aspects of warfarin and indeed anticoagulation. Our speakers are nationally recognized in their everyday roles and will provide three differing perspectives of anticoagulant prescribing, from specialist nursing to pharmacy to a medical angle. Now, importantly, there's opportunities to ask questions, and you can do so either using the chat function or the Q&A function on the screen in front of you, and we'll be monitoring as we go along. After each speaker, there may be the opportunity to ask one or two questions, but there's also 15 minutes following the last presentation where we can have more of a roundtable discussion. So our first speaker this afternoon is Hayley Flavell. Hayley is an anticoagulant and thrombosis clinical nurse specialist at the Royal Bournemouth and Christchurch Hospitals NHS Foundation Trust. And I hope she doesn't mind me sharing this with you, a practicing nurse for over 30 years. The title of her presentation this afternoon is Managing Skills, Opportunities and Challenges in a Nurse-Led Warfarin Clinic. Welcome, Hayley.
Thank you. So I think probably first of all, next slide, we need to identify that in the UK, there is a wide variation in anticoagulant service provision, i.e. it can be provided by secondary care, primary care, specialist, community, and by pharmacists. And anticoagulation can be provided by a variety of practitioners, from highly specialised in just anticoagulation, or by professionals who provide anticoagulation management as part of wider roles and delivered by doctors, pharmacists, scientists and nurses. I manage an anticoagulant service based in secondary care run by highly specialist nurse practitioners who provide VKA management, but also provide DOAC initiation, bridging, etc. in Bournemouth and Poole. So how do we manage skills in anticoagulation? Next slide. So we would all like to be super nurses, super pharmacists, super doctors, but anticoagulation is a rapidly changing service, and it's sometimes difficult to keep up with the ever-changing face of anticoagulation. And even if you're providing a service that only manages warfarin, you have to be aware of the wider context of anticoagulation. And there have been some massive changes in anticoagulant drugs since the development of warfarin after the deaths of hundreds of cows from eating mouldy sweet clover silage in 1948. NICE produced its technology appraisal for dabigatran and rivaroxaban in 2012. Apixaban in 2013 and edoxaban in 2015 for stroke prevention in AF, which of course the NHS is legally obliged to fund within 3 months. You need to keep skills that keep up to date with the expanding licenses of these drugs like CAD and PAD, And of course, it's not just knowing what drugs are licensed, but knowing the dose regimes, different doses for different ages, different doses for different indications, and different doses for different renal clearances, for example. And to maintain your skills, how do you do that? How do you keep up to date? It can be through formal education, networking, reading research articles, and learning from the information provided by our brilliant pharmaceutical industry. But in a nurse-led anticoagulant clinic, you also have to have IT skills, be able to run computerized dosing programs, be able to calculate TTRs, and know how to fix simple glitches, normally in my case caused by me. You need skills of being an excellent teacher and counsellor. You might offer the best service in the world at titrating doses of warfarin, but unless the patient understands the importance of taking the drug and the factors that can affect the anticoagulant, you're unlikely to run the best anticoagulant service in the world. If you're a lone anticoagulant practitioner running a service, then I'm afraid you have a massive workload. There will be a high expectancy from you. I'm very fortunate I can utilise the skills of a small but highly skilled team that have different strengths. I have a practitioner who is my computer queen. She'd probably prefer to be called Princess, and one who's excellent at patient education. She manages to get through to patients when the rest of us just don't seem to be able to make that click. As a manager's role, it's to manage and nurture the skills of the team, and we're only as good as the team that we manage. Next slide. So what are the challenges of a warfarin anticoagulant service? Years ago, patients would be diagnosed with AF and a referral would go to anticoagulation services. And whether you use Gotto, who states it takes 1 day for a clot to form, or some research that says it's as little as 5.5 hours for a patient with AF for a clot to develop, anticoagulation is a matter of urgency. I think we would all agree it's no longer acceptable for a delay in initiation because the clock is ticking. So I'm sure, like everyone else, we offer a same-day service for our AF clinic, and that in itself can be a challenge. Next slide, please. Warfarin itself, of course, is a challenge, but of course we know the challenges of warfarin, the interaction with diet and drugs, the narrow and different therapeutic ranges based on thrombotic risk. We know the need for regular INR monitoring because a TTR of 70% equates to a stroke reduction of 70%, but the benefit is lost if the TTR is less than 50%. We know the bleeding risks from half-lives, but there are also challenges of the DOACs, the 10A inhibitors, apixaban, rivaroxaban, and edoxaban, and the direct thrombin inhibitor, dabigatran. We have complacency of the danger of these drugs. Danger, for example, if an unconscious patient arrives in ED and isn't carrying an anticoagulant alert card. When the clotting screen comes back and the INR is high, you tend to know that the patient's taking warfarin, but it might not be so easy to identify the patient's on a DOAC, or you want to know which one for reversal. We know that rivaroxaban can produce a prolonged PT and APTT, dabigatran, prolonged APT, but sometimes apixaban doesn't show. Then you have the challenge of doing drug levels. And we know that most warfarin patients will take their drug around 6 in the evening. But what was the last time that unconscious patient took a once daily like rivaroxaban or edoxaban? Do they take it in an evening or in a morning? Do patients have greater complacency with the drug, where a healthcare professional is monitoring to check you've taken it, or does somehow warfarin seem more important, so there is greater compliancy? If, for example, you're converting a patient from warfarin to a DOAC, you've got the challenge of helping a patient choose the right anticoagulant drug for them. Is it once a day, twice a day? Availability of reversal? Do they use a Dosset back What's the kidney function? How close are they to their 80th birthday? What's their weight? How stable is their weight? Knowing patients you can't convert, like the mechanical heart valves and the triple positive antiphospholipid. What drugs are they taking? So anticoag services have many challenges, but over the last 14 months, the greatest challenge to all anticoag services has, of course, been COVID. The National Clinical Guide for the Management of Anticoag Services during the coronavirus pandemic was published over a year ago, with a statement saying anticoagulant services may not seem to be in the front line with coronavirus, but we do have a key role in continuing to keep patients on anticoagulants as safe as possible. Next slide, please. This was the biggest recent challenge internationally, nationally, and locally for anticoagulant services. Patients were being advised to stay at home by the government and therefore reluctant to go outside their homes for an INR blood test. A large number of patients were also receiving shielded letters. Patients with COVID-19 or exposed to it were being advised to isolate, so again, unable to access phlebotomy. Sometimes patients had difficulty accessing phlebotomy services due to staffing levels at, for example, GP surgeries, phlebotomy services, district nurses. Then you have the instability of warfarin in patients with COVID-19. And of course, anticoagulant staff, like all staff, were being identified as being at risk, having to isolate. I had 2 of my own staff were being shielded. So we had to identify new ways of working. Locally, we use a dose and post service, which prior to COVID ensured next day delivery of patients' dose instructions. COVID impacted on Royal Mail delivery, delaying delivery, and eventually even stopping it on a Saturday. Next slide, please. We had already taken action before the 31st of March direction came out, and I'm sure we are no different from any other anticoagulant service facing the same dilemmas, and whom I'm sure did all the same that we did. We managed to secure 2 laptops with Global Protect for staff to work from home, which was a challenge due to the immense pressure on our IT services. To protect patients, we introduced blood tests by appointment only. Previously, we'd given patients the ability of just turning up with an open access. To enable us to prioritise patients for action, we contacted GPs, obtaining lists of shielded patients, and then cross-referenced against anticoagulated patients by the next due date of their INR. We identified appropriate patients to convert onto DOACs, set up remote training in clinics through Attend Anywhere video consultations. We checked bloods, counselled and converted patients onto DOACs, and we posted new alert cards and drug information and arranged home delivery of DOACs for shielded patients. We contacted the community PCN pharmacists through the Wessex AHSN to help GPs convert appropriate patients. Those that couldn't be converted, we discussed the possibility of patients buying their own machine to self-test, so further expanded the number of patients that we manage who self-test. We supported district nurses to visit shielded patients whose anticoagulant monitoring was critical at home, doing point-of-care INRs. We visited patients at home who required urgent emergency anticoagulation reversal with vitamin K to avoid admission to hospital. We validated and set up emails for patients to ensure patients receive their dose instruction without delay. And for some patients, we had to convert them to low molecular weight heparin. We then set up a review of patients converted to ensure safe and effective anticoagulation, checking adherence, compliancy, etc. Next slide, please. Although we already identified patients through a weekly report of patients whose TTR was less than 65%, and where appropriate converted patients from warfarin to DOACs, COVID forced us to do this on a far larger scale, and no longer was it about poor TTR, but it was about other safety indicators, i.e. reducing patients' requirement to leave their house for INR monitoring. In the first 6 weeks, we converted 246 patients to DOACs, performed 112 reviews, and converted 284 patients onto email. Next slide, please. So how has the challenge of COVID changed the face of warfarin? At a local level, I know that of my 2,183 warfarin patients, I now have 318 patients who are mechanical heart valves, 62 patients antiphospholipid. I've got 33 patients with an INR target range of 1.5 to 2.5 because of bleeding risk. I've got 223 patients with a higher range of 2.5 to 3.5, 168 range 3 to 4, and even 25 patients that are highly thrombotic, we've got on a range of 3 to 4.5. We now have a very different makeup of patients still on warfarin. We have patients with higher bleeding risk, but also higher thrombotic risk. We have patients whose weight is above 150 kilos, who have in themselves a range of other healthcare issues. What we do know is that those patients in the future who are on vitamin K antagonist anticoagulation will be the more complex and fragile patients, needing much closer management. And this is what's already being reported nationally, that although we're seeing the reduction in the patient numbers on warfarin, we are not seeing a correlation in the reduction in the number of INRs and dose interventions. I think that anticoagulant services with warfarin are going to become even more specialised as the number of patients on warfarin reduces. So will the knowledge of managing these patients by general clinicians, raising concerns over safety. And of course, COVID has caused other challenges. The high thrombotic load of COVID has required new national, local guidance to be written, using far higher doses of anticoagulation for prophylaxis, and the challenging of managing those patients who have thrombotic events with COVID, particularly thrombosis at unusual sites. I would hope in the future that on diagnosis of AF, only those contraindicated to DOACs will start warfarin, and only those that remain on warfarin are those patients who have chosen to, or it's clinically correct to be on. Next slide, please. The challenge will be fewer patients on warfarin, so there will be the loss of the skills of clinicians from exposure of looking after patients on warfarin. So we know we have the more fragile, complex, highly thrombotic or high bleed risk, but we also know from studies from SIEGE that those patients on warfarin have worse outcomes. Now, it might be because they may be older, but they have larger hematomas. There is a threefold higher odds of hematoma expansion and a higher case fatality. So we need to ensure the patients on warfarin are closely and expertly managed. So what is the answer? Do we make nurse or anticoagulant practitioners, specialists, the sole providers to manage warfarin, whether in the community or inpatient dosing? Inpatient dosing, next slide, please. Inpatient dosing that will hopefully ensure the 7 rights of medication administration, the right patient, the right drug, the right dose, the right time, the right route, the right reason, the right documentation. But this will possibly further reduce the skills of those that are not specialists. But however you decide to manage the challenge of providing a warfarin service, we do have to recognise the challenge that patients on warfarin in the future are going to be the more complex patients. So education and skills of those providing the service is going to be crucial. We need to continue to develop the network supports, the national policies. We need to utilise patient skills and experience to enable the opportunities for service quality improvement and medicines optimisation. Next slide, please. I would like to see all patients being able to self-test if they want to, but we have the challenge of enabling our anticoagulant patients to have the same access to devices as diabetic patients. Next slide, please. The complexity of patients on warfarin means that we need to implement the improvements in communications between our services so that when a patient is admitted or discharged from a hospital, everyone knows what the anticoagulant management is for the patient. The anticoagulant software has the capability of interfacing with hospital systems and GP systems. We just need to make sure we're utilising the improvements our computerised dosing software companies have developed. Next slide, please. 10 years ago, I was asked if I was concerned I would be made redundant with all these new drugs that will be taking over from warfarin. The global anticoagulant market size is projected to reach 45.5 billion by the end of 2026, so in just 5 years. So we need to ensure we continue to manage the skills, opportunities and challenges in a nurse-led warfarin clinic. Next slide, please. I think it's probably unlikely any of us will be putting our feet up anytime soon. Any questions? Jim, I can't hear you.
Thanks very much, Hayley. That was superb. I think I could probably sit and chat through your slides for 20, 30 minutes or so. So many things that you raised, and it's quite interesting. You know, I'm in an area, Gloucestershire, where we don't actually have any specialist nursing anticoagulation services, you know, secondary care or community. It's all done within primary care. And one of the big learnings that I had from we did a project down in the west of England called Don't Wait to Anticoagulate. And one of the significant outcomes was just how poorly we actually managed patients who are on warfarin. So I think you raised some really valid concerns, you know, moving forward. This is going to be the, you know, your warfarin patients are going to be the highest risk patients for all that you just described. And really, should we continue to have that service long term? Should we be building that into a national cardiac specification? It's a really good question. So I don't think your job's immediately under threat, certainly not from your presentation. We've got a very quiet audience, and I'm going to remind you that if you have any questions, please use the Q&A or the chat functions that are on your screen. So I'm going to move on to our second speaker. It's a great pleasure to introduce Victoria Collings, or Vicky. Vicky's a consultant pharmacist in hemostasis and thrombosis and been working for a number of years in South London in anticoagulation clinics and working to improve referral pathways. So the title of Vicky's talk is Tips and Learning from an Anticoagulation Hospital Service, Pharmacist-Led. Vicky, welcome.
Thank you, Jim, for the kind introduction, and thank you to Joe for inviting me to speak today. So I'm going to first of all declare that I have no declarations, and I'm going to illustrate some points around anticoagulation management in our secondary care clinic with 3 cases. These are all real cases that we've managed recently in our clinic. Our clinic is secondary care focused, but we manage all the warfarin patients in our area, and we also have a DOAC service which I lead, and it's a mixture of nurses and pharmacists who manage these patients. Okay, so the first case is a 83-year-old female, and she's a care home resident, and she's bedbound and dependent on the staff for all her ADLs. And this is her sort of weight and renal function and so on. And to give you a bit of background about her thrombosis history, so back in 2016 she had a superficial vein thrombosis which was treated with 6 weeks worth of heparin and then stopped. And then in January of last year she had an unprovoked PE, and this was a segmental pulmonary embolism bilaterally, and she was treated with a apixaban at that time. And she was given the standard loading and treatment dose. She was in hospital for a number of weeks and had no problems, and then was discharged. About 6 weeks later, she was admitted back to hospital with PR bleeding. She wasn't compromised at that time and had no drop in her hemoglobin. And the bleeding was investigated, and she was seen by the colorectal team, who felt this was likely to do with her severe diverticular disease and also her hemorrhoids. And she was switched to heparin at that time and then put onto warfarin due to the lower rates of mucosal bleeding. She has some other concurrent conditions, as you would expect of someone of her age, mostly some cardiac conditions, but she also has dementia and some asthma. So these are her medications. So she's on warfarin with a standard target of 2 to 3. She's on donepezil, mirtazapine, memantine, levothyroxine, omeprazole, and paracetamol. So nothing that will increase her bleeding risk. But the main concern with her is that she had this poor time in range. And as obviously Hayley said, we know that and understand that patients with poor time in range not only are increased risk of having thromboembolic complications, but also all mortality risk is increased in patients with time in range of less than 65%. And unfortunately, she's had 2 INRs of more than 10 in the last 12 months. So, and there was no obvious cause for this. Leading cause obviously being patients being given concurrent medications, particularly things like antibiotics that may increase her INR, and obviously patients who have poor adherence, and neither of those applied to her. She is in a care home, so she's well looked after, she's well fed, and so there's no huge variability in her diet, and obviously her medications she's assisted with her medication administration. And we understand that any INRs more than 4 increase your bleeding risk significantly, and the most serious bleeding that we're all most concerned about is intracranial bleeding, and we know that for every point increase in INR increases your risk of intracranial bleeding 2-fold. And significantly, any INRs more than 9 are associated with a much higher risk of bleeding, and around 20% of patients who have an INR of more than 9 will go on to have a serious bleed within the next week. So despite these 2 INRs of more than 10, she's never actually had any PR bleeding since that initial 6 weeks post her PE, and she never had any bleeding complications associated with those 2 INRs. Any patients that do have INRs more than 10 are always discussed as part of our weekly MDT, and we go back and review the case and see if there's any improvements that we can make to their management, and also obviously go back to a risk benefit and discuss anticoagulation options for her. And the outcome of that discussion at our MDT was to offer her a switch for a VT prophylaxis dose of apixaban 2.5 twice a day. And this again was then in turn discussed with her next of kin and with her GP around what would be her best interests for her going forward. So she was seen in the DOAC clinic for a switch. Her INR was 3.2 a couple of days before the consultation. The full history and decisions were explained with the next of kin, and they were very happy, as were the GP, to go ahead with the switch to 2.5 milligrams twice a day, and that she started that 2 days later. And the plan was for her to be followed up with on the telephone with the care home staff in 4 to 6 weeks, but also with an open access for them to contact us with any concerns or any bleeding, obviously in the interim. So we're now about 3 or 4 weeks since we switched that lady, and she hasn't had any bleeding complications yet. So we're optimistic and hopeful this will help with her management going forward. One of the parts of the document that Hayley highlighted in her presentation was this sort of pragmatic approach to switching between DOACs and to DOACs from warfarin. So if any of you have looked at the SPCs, you'll be aware that all the DOACs have slightly different target INRs at which they advise that it's safe for you to switch from warfarin to their agent. And obviously during the COVID-19 pandemic, when we were trying to avoid patients coming in for unnecessary blood tests, we were guided by this pragmatic guidance that's supported by the European Society of Cardiology. So anyone with basically an INR of 2.5 or less could start the DOAC immediately on the next day. And those that were having slightly higher INRs would hold for 24 hours or 48 hours. And we'd only really consider repeating the INR if it was very high. So it'd really be, if it was above 4.5, then we'd be concerned and perhaps want to hold it for 72 hours or more, or consider repeating where phlebotomy and things were pragmatic and sensible. So this is something that I think has changed our practice, and we'll probably move forward with this, whereas previously we were checking INRs on the day of switches. Using remote consultation and switching people like this has actually proven to be very safe and actually very convenient for most people. Okay. Oops, I have done something weird with my slides. I'm sorry. There we go. Oh, okay. So the next case that I have is another gentleman who was seemingly a fairly straightforward switch. Again, this patient was switched during the early phase of COVID-19 last year, in end of March, early April. He's a 93-year-old gentleman who was on warfarin for atrial fibrillation. Has a CHA2DS2-VASc score of 3, has blood of 1, pretty reasonable renal function for his age. He lives alone with no care package, was fully independent, but due to the COVID-19 travel restrictions and visit restrictions, he was having no friends or family visiting. And previous to that, he was having family or friends visiting him at least once or twice a week. He was also quite hard of hearing, so this made remote consultations rather challenging, particularly for the people who had to sit in the room whilst we were having those consultations, as we had to keep our voices nice and loud. So he was on warfarin with pretty good control, INR of 2 to 3, and some other medications, as you can see. He has a Dosset box, which he was using to manage all these other medications. His main concern and the main reason why we identified him for a switch is because of the COVID-19 pandemic, and for him to have to attend the hospital for biochemical monitoring due to his age and his frailty. And after the consultation with him, he agreed to switch to edoxaban 30 milligrams once a day. And again, he was able to consent to that switch, and we arranged for the medication to be sent via our outpatient pharmacy service. We were couriering medications to patients. I mean, here in South London, we obviously have quite a dense population, but the actual distance people have to travel is not that far. But most of the medications would be couriered for these patients. About 6 weeks after he was switched, his biochemical results were monitored by his GP, and he was found, unfortunately, to have a drop in his hemoglobin. So whilst this seems like a straightforward switch on the face of it, these things don't always turn out that way. So he, back in early March, he had a hemoglobin of 110, so quite a significant drop. We were liaised with the GP and then contacted the patient to advise him to hold his anticoagulation whilst he was having this drop investigated. And his GP arranged a fecal immunochemical test, a FIT test, which was part of the referral pathway for 2-week wait gastro referral at that time. The telephone consultation was extremely difficult. It was very unclear what medications he was taking at that time. He told us that he had run out of the edoxaban despite us having sent 3 months supply to him, which is a standard policy in Southeast London at that time, about 6 weeks before. He had a dosette box for his other medications, but the dosette box he was using was for an old date, it wasn't for a current date, and he just seemed in a complete muddle. We didn't have video consult, we were just doing telephone, and it became very challenging to establish really what he was doing and whether he had taken any of the edoxaban, to be honest. So we referred him to a community pharmacy team that we have in Lambeth, who are able to provide home visits to patients. And we were very lucky that they were able to go in and see him. We were very concerned that he may have had stockpiles of dosette boxes and all sorts of medications, which, to be honest, the only way you were going to see that was to go into his home and to have a look. So for him, actually, the community pharmacy team went in, and he did have a cupboard basically with a stash of old dosette boxes, and they helped rationalise him, remove anything that he didn't need, and with his consent, obviously, and then we could safely continue to manage him. His fit test actually turned out to be negative, but his urine was positive for blood, and unfortunately he was found to have bladder cancer. And so his anticoagulation was held whilst he was waiting for a procedure under urology to remove that tumour, and the plan is for him to restart that after he had that procedure done. Okay. So I've got some sort of tips that we've put together about remote monitoring, and obviously sort of the 101 is really to confirm that you've got the right patient, which I know sounds obvious, but it's not always obvious, particularly if you've got a large family who are living together, and you need to obviously consider the implications for consent and confidentiality if you are discussing with other people. Make sure the patient can hear you correctly, because there's no point you getting halfway down your sort of spiel about who you are and why you're calling them if they can't hear you. This is particularly a problem sometimes with mobiles if people are moving around and the line's not very clear. Introduce who you are and the purpose of the consultation, and make sure that they are able to speak to you in privacy. So, you know, sometimes if you're phoning them, particularly early lockdown, it wasn't a problem because people were mostly at home, but later on, if people were going out and, you know, they're on the bus or in the supermarket or whatever, it's not necessarily appropriate for them to have the consultation. We have a diverse population here in South London, so we've used language line interpreters an awful lot to do three-way consultations, and that's been invaluable for many of our patients. You know, do explain if there's any background noise. You know, if you're working from home, for example, and you have a toddler, or if you're typing notes or there's other colleagues in the room, all of these things will help reassure the patient that you're, you know, of any background noise that might be going on and might be unexpected. Having a clear plan for patients that don't attend, and sort of your policy with regards to callbacks. We do have scheduled times for our appointments, just like normal outpatient appointments, but with all the rushes with the COVID-19 changes, often these appointments were scheduled very close together. And as I'm sure many of you have conducted telephone consultations, they are not quicker. So you still need a good amount of time to conduct that consultation. And if you're using language line, for example, that can actually increase your consultation length by a significant amount. So if you are calling people late, then you know, making sure that there's like a policy around what you do with if they don't attend, and how often you call them back. I think not rushing on the phone is important, because without any of those non-verbal cues, it can be much more challenging to build rapport with a patient. So doing the things that you would normally do face-to-face can sometimes become more difficult, but using their name, and again, how you show active listening when you don't have those non-verbal cues is a challenge. So using your ums, using your ahs, you know, sort of confirming you are actually still there and you're still listening. And I find especially if patients have had problems with side effects, going back and summarising what they have told you shows that you have been listening and that you are taking their concerns seriously. We definitely want to allow specific time to allow them to ask questions. So, you know, asking them, do they have any concerns? Do they have any worries? Do they, and asking them specifically about questions. I think that some patients can be very a bit more worried or less open on the telephone compared to face because they have none of those non-verbal cues. So specifically allowing them to do that is important. When particularly with switches with the medications or with dose changes with warfarin, using repeat backs to confirm that they check it and then check that they understand the plan that you've put in place and explain how you're going to be following that patient up. Obviously, always want to be giving your worsening care or any safety netting advice, specifically how the patient can contact you. So do they actually have the telephone number? Do they know where that is? You know, is it on that anticoagulation alert card they got 10 years ago that's like back in their bus pass that they haven't used for 6 months and they don't know where it is? So making sure you've provided them with that, that information. We found using the patient support network really helpful in that, similar to the case I just spoke about. So using their community pharmacist who might be going there every week to deliver their medications, their district nurses, their family and their friends who might be seeing them as part of a support bubble, any carers as well, to make sure that you can support them with particularly any switches. As we know, anticoagulants and switching anticoagulants is not without its risks, so making sure you use those if possible. We didn't have the facility of doing video consults, but we were doing telephones, and we used to do telephone check-ins, particularly for patients that we were worried about. And so we would then check in with them a few days later just to check everything was okay and that they'd gone ahead with their switch. They'd received the medications, and just to allow them to ask any other questions that they wanted. And again, these were time consuming, but something I felt was really important for safety netting our most vulnerable patients. And then finally following up with any written information, posting it to them or using emails. And I know there's a lot of primary care colleagues have a text message system where they can text over patients information and web links and so on. So using those sort of systems were really helpful as well. So my last case is slightly different. So this is a gentleman who has a mechanical mitral valve, and obviously this is an indication for which a DOAC switch wouldn't be possible. He has an INR target of 3 to 4, but still has a poor time in range. But his anticoagulation options are very limited, and warfarin is truly indicated in this case. And whilst he is still young, we know that patients who have this higher target of more than 3 will be twice as likely as those who have a target of 3 to 4 to experience major bleeding. And again, his time in range was poor, and whilst he didn't have any very high INRs in the last month, this is definitely, there's still room for improvement for his management. He reports having good adherence with his warfarin, takes it regularly every day and rarely misses doses. He eats a normal home cooked diet, but avoids greens and leafy vegetables. And also he's aware about alcohol and limits his alcohol intake and knows not to have binge drinking. And this is again something I see commonly, perhaps where messages get worn over time about greens and vitamin K, where patients think, oh, I can't eat that because it affects my warfarin. And actually this case will illustrate that greens and leafy vegetables and vitamin K supplements are really important for patients, particularly those with labile INRs. So he had a consultation in our annual review clinic, and this poor dietary intake of vitamin K was identified at that consultation. And we know that it increases the effect of the warfarin and increases the risk of bleeding. At initiation, all patients should be advised to maintain their intake of vitamin K, and this should always be rediscussed when patients have high INRs or at their annual review. But there are many challenges associated with modifying patients' dietary habits, as we know from all the problems we have in this country and globally with obesity. We know that getting patients to modify their diet is extremely challenging. So there's a couple of different tactics that we use to help improve their vitamin K intake. So it is recommended that that patients should have 100-150 micrograms of vitamin K, or alter their dietary intake of vitamin K to ensure this kind of consistency with their food, and that will reduce INR instability, improve their time in range, and that has included patients who have this unexplained instability in their INR. So the first option is to think about having oral vitamin K supplements. Unfortunately, there are no certified formulations that are designated for maintaining and stabilizing INRs. There are really two options. One is for neonates and for children for vitamin K deficiency, and then also multivitamin preparations, the standard multivitamin preparations you buy over the counter. But there's a wide variety of different supplements available. Typically, they only contain about 75 micrograms, but that can vary hugely between brands. Some of these vitamin supplements are highly costly and not necessarily more effective. The formulations can vary between tablets and liquids and so on. And a lot of the kind of common multivitamin mineral supplements actually can contain vitamin K1 or vitamin K2, and these are not bioequivalent. So they have different bioavailabilities and different absorptions, and therefore have different pharmacological effects. And therefore are not interchangeable. And so if people change between multivitamin preparations, that may also affect how well their vitamin K supplement is working. And also of note, multivitamin supplements often contain vitamin E, and that actually inhibits the absorption of vitamin K as well. One of the other methods we use in our clinic is to use frozen spinach. So frozen spinach is in pre-prepared portions, and this is a very kind of cost-effective option for patients to maintain their intake of a green leafy vegetable. It's all pre-portioned. It's about 30 grams per portion, and that provides about 110 micrograms of vitamin K1 per portion. Vitamin K only contains vitamin K1, and it's also very heat stable, so whether you have it raw or whether you have it cooked, it still maintains the same level of vitamin K1 in the portion. It can be integrated into their normal diet, soups and pastas, curries, and again, some of our younger patients like putting it in smoothies, and so again, that's really helpful for patients to incorporate it in different ways. Ideally, it should be consumed with some oil or fat-containing foods. So something like if you are going to put it in a smoothie and then adding something like a Greek yogurt or something to improve the amount of fat in it to help aid absorption through sort of sequestrants and bile acids. And using this sort of method actually provides patients with not just the vitamin K, but also the addition of vitamin C's and folates and potassiums, which are the micronutrients that are really important for their diet. So this gentleman was followed up 6 months later and is found to have an improvement in his time in range. He's had no INRs more than 5, and he's eating greens and spinach most days as part of his diet, and that's it's improved his control and obviously his risk of bleeding. So there we go. And so that's the end of my presentation. Thank you.
That's superb, Vicky. I love the summary on tips for telephone consultations. That's transferable. That's not just around anticoagulation.
Yeah, exactly.
That's around all telephone consultations, and also highlighting the vitamin K issue. I've never thought in that dialogue with patients when starting them on warfarin to talk about the need for vitamin K. It's usually trying to tease out what vitamin K sources they may be having excessively. and causing the problems. One of the things I learned when I came down to Gloucestershire was about the asparagus season, which is just at this point of time. We're quite close to the UK centre of asparagus growing, and we used to get INRs all over the place at this time of year, although the number of patients on warfarin are much reduced. So your third case there, in fact, dovetails nicely with a question we've got from Mohammed. So it's a patient with a mechanical heart valve, and he says, he has a patient who's on warfarin and subtherapeutic INR for months, no resistance mutations or no compliance issues. What can he actually do?
Yeah, again, this is something that is not uncommon, particularly for patients that if it is dietary related, then certainly look at his diet. Veganism is the kind of nemesis, I would say, of warfarinization. So, but keep going with warfarin, and it would be. We do have some patients on very high doses of warfarin that would be concerning perhaps, but keep going, keep increasing the dose as per your policies and your protocols, really. And if it's getting probably much more than 30 milligrams a day, then maybe try something else. You could try acetylcholine maybe, but if he's got a mechanical heart valve, you're stuck, I'm afraid. I don't think there's much options. We're going to have to keep going with the vitamin K antagonists and bridge them where appropriate.
Great. So really, it's about persevering, isn't it?
Yeah, persevering. Exactly.
Okay, thank you very much. That was fab. So on to our last speaker, who for general practice audiences rarely needs introduction. So it's Matt Fei, Dr. Matthew Fei, and Matt's a GP in Bradford, and he's also the Chief Clinical Executive of Affinity Care, which is a super practice based in Bradford. Matt's one of the best known figures in UK primary care cardiology, and with interest right across the spectrum of cardiovascular disease. He has a wide remit for his talk today, which is anticoagulation and the role of primary care. Over to you, Matt.
Thank you very much, Jim. I'm just going to echo your comments earlier about the Primary Care Cardiovascular Society, where, of course, we spend many a happy Tuesday evening on our virtual meetings. Unlike Vicky, there's several things I need to just declare, although hopefully we won't run into much of this in the generalities of what we're going to talk about. So what is the role of general practice? And I'm going to go through a few scenarios, but I would suggest that one of the major things that us GPs do is that we are case finders. So we take the patient's story, we listen to what they have to say, and we try and make some sense of what investigations we may want to do next to try and elicit a particular diagnosis. And I'm going to start, because of course this is National Thrombosis Week, that we start with general practitioners and consideration of VTE. Now, VTE is incredibly common. It's definitely something we should be considering frequently. And of course, we have it in exactly the same as our AF population, particular high-risk groups. Unfortunately, one of the highest risk groups that we have in our population for VTE events are people who have actually been under our care in hospitals. This is even more true just at the moment, where we're talking about COVID and the fact that COVID is an incredibly sticky bug. I'm not wishing to self-promote, but I am chairing a session on Friday with some of our national experts about coagulation and COVID and the use of anticoagulants. So that might be something for the diary, but it's an important topic that we try to consider. And there's a lot of death a year because of this. Now, part of our problem in general practice is how we've been taught about thrombosis. So when you talk to most people in the primary care setting, they'll tell you that they're going to consider somebody as suffering from a possible DVT only if they have leg swelling. It's a common feature It's also one of those things that causes a lot of referrals, I would expect, not only to my cardio clinic and echo service, but Jim's cardio clinic and echo service, where we get people with bilateral swollen legs. So as a symptom, it's a very common symptom in general practice. Some of it purely due to gravity. Of course, some of it iatrogenic due to our ongoing attempts to reduce people's blood pressure and the use of things like dihydropyridines and alpha blockers, which cause a bit of peripheral edema. But when we look to the literature, what we find is that actually unilateral calf pain is an incredibly important sign. And not only that, that calf will be tender on palpation. So although when somebody comes in and we're considering a VTE episode as a cause of their leg pain, when we reach for our tape measure, actually what many of us should be in fact doing is actually talking to the patient about their risk factors and actually physically examining the calf. Now, I've spent a lot of my time knocking about in the world of atrial fibrillation, and we have one of those magical numbers, which is the 295 times somebody has to fall before anticoagulation. The risk of the anticoagulant that you might give to prevent stroke is outweighed by the benefit, the risks of bleeding. Now, VT has one of those kind of numbers as well, of course, and it's the 40%. And it's that idea that 40% of people dying of pulmonary embolism have actually presented to their primary care clinician in the previous weeks with symptoms which may have been suggestive of pulmonary embolism. What was missing was the clinician putting those pieces together and thinking that this person could be at risk of pulmonary embolism and ensuring that's been eliminated. Now, we've been setting up a little bit of work within Affinity Care PCN to look at this, because when we've looked to our computer records, when we have a very good DVT pathway in Bradford to make people streamline through the system from community to secondary care and then back into our care once more. When we've looked at this, what we find is there's virtually no incidence of low Wells scores being recorded into the system, which would suggest that by the time the GP is actually putting the data into the clinical system, they've already made the assessment, they've already considered that this is DVT, and they've made the Wells score fit, or they've automatically calculated it in their head, and the Wells score is always high. What we're forgetting is that the Wells score is part of the assessment. And if somebody is at low risk through a Wells score, then actually what they require is a D-dimer to make the next step clear. And if they have a positive D-dimer, then they should be sent through the normal process to be imaged and a diagnosis made or refuted. Now, part of the concern may be the clause within our national guidance that says that if you have a low risk Wells score, and a D-dimer is required, and that D-dimer test is going to take more than 4 hours to undertake, and the result received, then you need to anticoagulate the patient the same way that we used to use low molecular weight heparin, and Bradford's been using rivaroxaban for some years, that the patient needs to be fully anticoagulated while awaiting that test. Now, we could raise that concern that in those low-risk patients, anticoagulating for that length of time, waiting for a test result, just seems to be a little bit uncomfortable for us in our clinical minds. So what we're doing in Bradford in Affinity Care is that we've acquired a couple of point of care D-dimer test machines, and we're going to be using these to see if that actually starts the GPs considering lower risk patients and finding more thrombosis. Because the one thing that is true about thrombosis is that it does harm. So, of course, our DVT pathways aren't there to necessarily find deep vein thrombosis. They are more of pulmonary embolism risk pathways. And of course, pulmonary embolism is a very high mortality situation where 1 in 4 patients who suffer a pulmonary embolism will present with death. So even these low risk patients need to be assessed, because they may be low risk when they present to us in general practice, but a couple of weeks later, as that clot progressed, they become much higher risk but they don't want to go back to bother the GP because they said everything was fine. So case finding in VTE is complex, and we need to try and improve that situation. The much commoner reason that GPs, of course, get into anticoagulation is because of atrial fibrillation. Now, atrial fibrillation prevalence in this country seems to be falling. Is that because COVID has been a cure? And of course, the answer to that is a very clear no, it has not. What COVID has done is it has stopped that incidental case finding that general practice had been doing so well. So it's always very nice for a patient to come in and say, Dr. Fei, I think I've got a heart rhythm problem because I keep getting these irregular palpitations in the middle of the night. And I smile at them and say, I think you've got atrial fibrillation. Unfortunately, 30 to 40% of our patients will get no symptoms. They will have elevated stroke risk. They do require anticoagulation, but they will have no symptoms that their heart has changed from sinus rhythm to atrial fibrillation. And in this cohort of patients, we need to have that incidental case finding that we've been doing so well. We've used our flu clinics, we've used the long-term condition reviews, many of which have become virtual in the COVID period. And this means we've missed out on those opportunities to take a pulse and to find atrial fibrillation. So we need to redouble our efforts and focus once more. Now, while we've been busily hiding from our patients and doing most of our consultation virtually, technology has been developing very nicely to allow us to try and find atrial fibrillation without actually touching the patient. You're never going to get around the fact that taking a simple pulse is by far the cheapest and most effective way of finding atrial fibrillation, but we can pick it up through automatic blood pressure machines. We've encouraged many patients to purchase such devices to allow virtual assessment, but when that monitor is suggesting an arrhythmia, that needs to be reported back to us so we can get an ECG done. There's now even apps on your phone that can use the camera in a photoplethysmography manner to work out if you've got atrial fibrillation. Clearly an ECG needs to be done afterwards, but actually the ECG machine has moved into the community as well in the form of the Apple Watch or the cardio-mobile devices. And so there's many ways that an actual ECG can now be recorded from the patient. And of course, if atrial fibrillation is identified, appropriate stroke risk classification with stratification with the Chad's VASC schema is important, and we can then ensure that our patients are appropriately managed. But the other thing, of course, is that anticoagulation is spreading deeper into the general practice realm. We do a lot of preventative medicine in cardiovascular disease. Now, most of us are very aware of the fact that GPs need to be coaching our patients around lifestyle, of course, encouraging them all to stop smoking. It's great that we're down to 15% of the population now smoke compared to the 30% when myself and Jim were at medical school. But we need to keep working hard on that. And we know that some of our patients who had previously stopped smoking have relapsed during the COVID lockdown and the stress and emotion that's caused. So we do need to continue back on that. But what we also find is that within those patients with known vascular disease, where previously the management plan was purely to give them aspirin, we're now seeing that in those high-risk individuals, those people who have got multiple vascular beds involved, so heart and head, heart and kidneys, heart and legs, these now need to be considered for what many would call the COMPASS intervention, after following the study that showed its benefits, where actually what we need to do is combine an antiplatelet, which is aspirin, with rivaroxaban at a cardiovascular dose, a 2.5 milligram dose, to ensure that their risk is reduced further. Clearly, always in conversation with the patient. But if you have a conversation with a patient who is known to have peripheral arterial disease and you discuss with them the reduction of 30% limb loss risk, you'll find that many of the patients are keen to take you up on the offer. But this now means that more anticoagulant medication is in the community. It does mean that our colleagues in the hospital, particularly the ED departments, could be faced with a patient who says they're on rivaroxaban, but doesn't mean full formal anticoagulation, just cardiovascular protection. So it's important that we ensure that the patient record is updated, that the patient understands to mention this to our colleagues within the ED and secondary care environment. Of course, we're getting more complex situations as well, and Hayley and Vicky have already outlined many of these issues, particularly around bleeding. So what do we do when the patient comes to us and says that I've had my anticoagulant because of my massive PE of unknown origin, and I now get a bit of bleeding around my teeth due to this rivaroxaban or DOAC medication that you've used. Do we tell them to stop it? Or do we start trying to ensure, as we've just heard from Vicky, that there are ways to make sure that the medication is preserved and we use it better? So bleeding events need to be clearly described to the clinician. The clinician needs to know when to reach for help from primary care. We always have had issues around adherence, whether that be warfarin, DOAC, or any other medication. The thing that we always have to be conscious about with anticoagulation is that it doesn't make you feel better, it just makes you live longer. So it's important that we communicate that to the patient so that when they tell us they've stopped taking those DOACs, we didn't expect them to feel any better because of them, but we do expect them to not have serious consequences. So it's important that we involve our community pharmacists. Those of us who work in PCNs are very aware of how much we're having pharmacy suggested to us as the next member of the primary care team. And this is a fantastic role for our practice-based, our PCN-based pharmacists to support our patients with adherence issues. The other problem with prevention, of course, is that it is not 100%. We will prevent many events, but we won't prevent all events. So it's need to have a clear plan with the general practitioner to ensure that they are aware of when an event happens, what do we do next? So if somebody suffers a stroke on their well-adhered DOAC or their well-controlled warfarin, what is the next step? Are we talking to our secondary care colleagues or our tertiary care colleagues for a left atrial appendage occluder, or are we trying to think about maybe moving them from a DOAC to a VKA so that we can use a higher level of anticoagulation determined by INR on just pulse medication taking? We also need to be conscious of what we throw into the system. So although the DOACs do appear very fire and forget, they need ongoing surveillance. They need us to watch what we're doing with those medications, what we're adding into the prescription to make sure that they remain safe. And if we get all this right, our patients will grow older. And as they grow older, it is the nature of growing older that you'll become frailer, and some of the decisions can become quite difficult about when you may wish to stop or modify the medication. And I'll come back to that in just a moment. And then, of course, we have the issue of renal disease. So already heard from both Hayley and Vicky about the fact that vitamin K is a vital part of warfarin, not only making sure that people don't have too much or sporadically too much, like the asparagus season, but also that they don't have too little. And we need to make sure we keep an eye on that, the vitamin K intake. But it's also important for us general practitioners to keep an eye on the renal function of our patients when they're taking DOACs. So DOACs aren't monitored, I always say, like the vitamin K antagonists. We keep them under surveillance, and we need to keep watching them, because as we get older, people's renal function declines. We can also find that people's renal function can suddenly decline due to an AKI event where the anticoagulation could become uncontrolled because we've lost renal function. So when we're considering the DOACs in our higher risk population, particularly these renal patients, it's really important that we make sure that they're prescribed correctly. And this is a fantastic piece of work done by Sue Wood when she was working in the north of Bradford, to try and make dosing of DOACs remarkably simple, that it just was a simple chart. You could read off the age and the creatinine, and you could come up with a pretty close assessment of what dose you need. The creatinine clearance, of course, is built into both System 1 and EMIS Web, which are the two big clinical systems in general practice. And we need to encourage general practitioners to use these. Also really important that we make sure that our patients know what to do if they become ill when they're at risk of renal problems. So make sure we've got good sick day rules that they know to adhere to, that they know to stop those medications which are going to cause AKI if they're in a situation where they're going to dehydrate. So education of the patient, particularly when they're using DOACs, is vitally important. So it's important to not forget those patients who are on DOACs. And again, this is a great function for the pharmacists who are coming into primary care as something that we need them to assist us with. We heard brilliantly off Vicky there about the changes of the modality of anticoagulation. So this is what we did within Affinity Care, because we were trying to ensure that patients weren't moved from warfarin inappropriately. So these aren't patients who are at higher risk of thrombosis if they're on a DOAC, or those patients who have been moved onto warfarin specifically to ensure that they had a higher range of anticoagulation from their therapy. So it was just a very, very simple idea that if warfarin was mandated, they'd be referred into our warfarin clinic. If warfarin wasn't mandated, and we worked through a series of questions to see how quickly we could move patients off warfarin onto DOAC intervention. What we've now found is that it's roughly 1 in 10 of our anticoagulated patients across the whole of Affinity are now on a DOAC rather than warfarin, and we have no new initiations for warfarin other than those who are mandated to warfarin due to the restrictions of what we can use for a DOAC. So this then raises that final question that I was asking with frailty and end of life questions. When is enough enough? When do we stop and withdraw an anticoagulant? Now, as I say, these medications are generally preventative, so they're trying to stop harm to our patients. But of course, it does get to that point where there is a balance between the potential harm and the potential good. And at that point, there is one person who can always mediate and try and actually weigh those risks up. And before you think that that's the professor in their ivory tower, of course it isn't. The person who is the final adjudicator as to whether or not they should take a medication is always the patient. We should never be in a situation where somebody's anticoagulant is discontinued by the ward round at the end of the bed and not involve them in that conversation. Unfortunately, I've had several patients being put in that situation who have chosen, when they were presented with the facts, to return to anticoagulants. So it's important to have that conversation with our patient. If we find that conversation difficult or challenging, that isn't a failure on the patient's side, that's a failure on our side. And that means that we need to learn how to communicate better using resources that can be found here at Thrombosis UK, but also other resources which we can find at other organisations such as the AF Association and Anticoagulation UK. We need to communicate in a clear and obvious way with our patient so they can make decisions, and they may make decisions that we disagree with, but we have to involve them in that decision making. And if they opt to have an anticoagulant, then we have to make sure that that anticoagulant is as safe as it possibly can be for that patient. But they carry the risk of the event, they also carry the risk of the bleeding. So in summary, what's the role of primary care in anticoagulation? We've got to find the patients to make sure that we don't allow Hayley to ever retire from work, because she's always got so many patients that we found that can benefit from anticoagulants. We need to monitor and support the patients who are on those medications, making sure we keep them under surveillance to keep them safe, and also suggesting switches when that's appropriate. And we need to use that long-standing relationship that we have with many of our patients to discuss when they may wish to actually discontinue their anticoagulant, accepting the risk that this will bring, but understanding why the risk of the medication may be unacceptable, considering the risk of the condition we're trying to prevent. Thank you very much for your time.
Thank you very much, Matt, for as ever a brilliant presentation. It's interesting that thread of importance of communication that's gone through all three talks. And in many ways, one of my most important roles as a healthcare practitioner is the advocacy of patients, thinking about what is best for this patient in front of me. I mean, sometimes I was just reflecting on some of those conversations, and probably one of the most important consultations I will do in a day is that patient with new atrial fibrillation, and taking time out to talk about the pros and cons and assess them. But sometimes that tends to come back on you sort of a year later, when someone has had a bleed or a complication, and that's that difficult conversation around, you know, are we continuing anticoagulation? Are we not continuing anticoagulation? And they're so convinced about the importance of continuing anticoagulation and the benefits, despite the fact it might be in their best interests to consider not taking it. They want to carry on, whatever the risk. And in many ways, it often reminds me that perhaps I am doing my job properly. And those issues around complex shared decision-making, terribly important. And it's a big issue, Matt. One of the things I think, I mean, we've got time, 15 minutes or so, or maybe just a little bit less to pick up some of the points you've made. But this, you know, the detection part of atrial fibrillation is going to be a real challenge moving forward. And you and I have discussed, you know, the current NICE guidance tells us that you should not make decisions around stroke prevention AF based on a lead 1 30-second tracing alone. Now, this might be a can of worms, Matt, and you may not want to go there, but what NICE suggests is that we should do a 12-lead ECG. But you and I know and can remember the patients who sat in front of us with the irregular pulse when we didn't have lead 1 devices, and by the time we got the ECG, they were back at a normal rhythm, and we'd missed the boat. And there is some European guidance, which you'll probably tell us about, around what we can do around lead 1 devices. And maybe this is occasion, Matt, where we identify ourselves as truly European and follow European guidance.
I'm actually going to be very pragmatic, actually, because I love quoting my studies. But when we think about what we do, Jim, with those patients who we think have a thrombosis, a DVT, is we anticoagulate them until we get that formal diagnosis through whichever form of imaging we wish. If I have a patient who I think has atrial fibrillation, why should I treat them any differently than I would a patient with VTE? And I should anticoagulate them until I get that 12-lead ECG that confirms the diagnosis. And so the first job of any clinician is to protect the patient. And if, because the system delays them getting to that investigation, I shouldn't allow that delay to actually cause risk and harm to my patient. So although I think we can cite lots of different papers, the ultimate answer to this is going to be the SAFER study publishing later in the 2020s. And in the interim, I think we treat on what we see and wait for confirmation. For me, in general practice in Bradford, I can get you a 12-lead ECG within the hour. Yeah. For some places where they're relying on their hospital services 20 miles away, that could take a couple of weeks, and that's completely unacceptable. So if we have a device that's suggesting that this is permanent, persistent, or paroxysmal AF, treat what we see, assess the risk, anticoagulate according to the patient's desire, and arrange for the 12-lead ECG.
But it's when, Matt, we've got that evidence on a 30-second ECG, and we are confident that that patient has atrial fibrillation, and the 12-lead shows that they're back in sinus rhythm. And what the European guidance has said, that if you have someone with expertise in reading ECGs, then you can make that decision around what's on you can make that diagnosis.
The humour in this, Jim, is that if the ECG shows atrial fibrillation, then the 12-lead ECG showed atrial fibrillation, then we got the diagnosis right, and the patient needs to stay on their oral anticoagulant as per the discussions that we've had. If the 12-lead ECG shows sinus rhythm and we're confident that the first ECG showed AF, then the patient's got PAF and therefore should stay on oral anticoagulant. But let's not argue with that nice too much. I think they did it with good intention.
Oh, absolutely. And they in the usual way, you know, they have their way of assessing the evidence. The other important thing you highlighted there is that, you know, 30 to 40% of your patients don't present with atrial fibrillation and palpitations, but ask them about breathlessness. We know that atrial fibrillation, going into atrial fibrillation, reduces your cardiac output by 20 or 30%. So the majority of patients who go de novo into AF will actually be breathless. So think with your breathless patient, you know, we think about respiratory things, we might think about heart failure, but think about atrial fibrillation as well. There is a question from Joanne, who's a pharmacist in Northern Ireland. So she's asking questions around patients on warfarin, mechanical valve, mild cognitive impairment, no support. The carers where she works wouldn't be expected to manage this, so presumably to supervise medication being given, and so it's transferred to district nurses to manage. Is there any alternative ways of managing that? Actually, we have through social services means by which we have a team that will visit patients at home, and there are all sorts of ways in which alarms and things they can put into the home to try and support patients in that situation. Though also, I'm fairly sure our carers are able to signpost patients to taking that medication where they visit. I'm not sure if anyone else has any other experience, either Vicky or Hayley.
I've got a fantastic nurse who's in the audience, so I'm not even going to attempt to answer that question because Bernie, who, as I say, is watching, would answer it so much better. I'm going to defer to Vicky and Hayley, where clearly in the middle of London, which I know, as you said, Vicky, is very built up, but at the same time can be very isolating. I'd be fascinated.
Yeah, so we have similar problems with patients here as well, as I'm sure everyone does, and certainly district nurses is an option. But a lot of our care agencies, as Jim said, can prompt patients with their medications. But we get back to the issue around warfarin not always being, for example, in a dosette box. And I know there's been big drivers to educate and train carers on assisting patients safely with their medications. So obviously medications being the biggest medical intervention that we all do on a daily basis, it's imperative for patient safety and for their management of their disease. So I think prompting from the carers, if that's possible, and the anticoagulation clinic being aware of this so that communications are sent clearly, and regimes are kept as simple as possible. You know, I feel that sometimes we do asymmetric dosing, so that means, you know, Friday this dose, Saturday this dose, and then Monday, Tuesday, Wednesday a different dose, to help keep them in the optimum range. But sometimes a slightly more pragmatic approach may be preferable, where you're only trying to keep the dosing as simple as possible to help support patients. Those sorts of strategies would be what I would advise. But if your carers in your area can't prompt medications, then that is a concern, then district nurses may be your only option. I don't know if Hayley has anything to add.
The only thing I can add, once you've gone through every other possibility in extreme cases, we have been known to have to convert patients onto low molecular weight heparin.
Yeah,
the final resort.
Yeah.
The other thing worth saying is that just don't assume if you've got someone where there's been problems with warfarin, then using dosette boxes, say for a DOAC, is going to solve that problem. You really have to explore exactly why, you know, that there have been problems with their INRs. I think you went through that, Vicky, in your talk, this thing about asking patients just to repeat what you've told them. And it's absolutely surprising what patients do not pick up. You know, you must take your rivaroxaban same time of day, and you must take it with food. And 10 minutes later, that's completely lost. We do rely to an extent on our community pharmacists who delivered the boxes to pick them up and to tell us if tablets are not being taken, and that, you know, out of the dosette box, and that can be quite helpful too. You mentioned, you know, coming back, Hayley, to your talk, you talked a little bit about DOACs and weight. And I noticed you used 150 kilograms as your limit. And I assume that's based on some of the work that's been done, well, the work I know of by Raj Patel down at King's, who's used rivaroxaban up to 150 kilograms.
Yeah, locally our guidelines states that we normally go up to 120, but between 120 and 149, we would actually do DOAC levels.
Right.
So we're fortunate that we've got the ability to.
So you actually have that. I asked my local lab, hematology lab, about DOAC levels. Well, you know, I may as well probably not have asked the question because it's not something.
I think I think the information that's coming through gives us lots of comfort for using DOACs between 120 and up to 150. But personally, I'd like to have the DOAC levels as an ability to check, particularly depending on the indication.
And at the other end? Oh, sorry, Matt.
The other thing, Jim, though, is that we also, as the rest of the care system, need to accept that actually people at these extremes of weight, particularly when we're using an anticoagulant for atrial fibrillation to reduce stroke, there's a lot of other stroke risk in there. And actually, we should be working with the patient to try and reduce the weight. So not only facilitates the anticoagulant, but actually is significantly reducing their cardiovascular risk. So, yeah, it's a whole system, isn't it?
It can become a bit of a target, you know, if you've got a patient who's brimming about 130, say, get your weight down to 120 and we can come, it can be that extra target.
There are even more challenges at the other end of the weight spectrum, where you've got patients who are under 50 kilograms. Those are the patients that I often discuss with experts, really, to get their guidance. I think we should finish with one more question that we've not answered. And again, it's from Joanne, who's in Northern Ireland. What guidelines are used to decide on commencing a patient on a PPI, proton pump inhibitor, when commencing an anticoagulant? She cites risk of fractures on long-term PPI, and very hard to convince GP to stop the PPI when on DOAC, but no other bleeding risk factors identified, not on non-steroidal, etc. Matt, is that?
I think it's a really interesting question when you consider that one of the high risk situations that we'd have thought of, that combination of aspirin and DOAC in the cardiovascular setting. So the COMPASS trial, there was actually a sub-study within that which looked at PPI use that didn't actually find any advantage to the patient at all. They only found that in the PPI limb, that they had more GI upsets, because as some of us are aware, PPIs can cause diarrhea and so on, but they weren't talking about full formal anticoagulation in that setting. As I've said so many times in presentations, though, remember that anticoagulants will make your bleeding worse. They don't make you bleed. So they are different from the antiplatelets and the NSAIDs that we're using, where they not only make you bleed worse, but they make you bleed in the first place. So I don't routinely prescribe a PPI with an oral anticoagulant unless there are other risk factors, low body weight we've just mentioned, but excessive alcohol intake perhaps, or the use of SSRIs and bisphosphonates, which are both gastric irritants as well. But I wouldn't routinely use them just because the patient's on an oral anticoagulant.
I agree entirely, Matt.
Sadly, can I just add one thing? I would also want to make sure we're checking things like magnesium and sodium, and also C. diff infection history, and those things would be compelling reasons to stop, as well as a history of osteoporotic fractures. So again, looking at the holistic patient history when you're thinking about deprescribing or prescribing a PPI. So I would agree. Yeah.
Thanks, Vicky. We often forget about magnesium, don't we, with PPIs. Sadly, we've got to the end of an hour and a half. It's been an absolute privilege, actually, this afternoon to listen to three superb speakers. Great presentations, as ever, learned a great deal. and they've been fantastic at answering my questions and those from the delegates. So thank you again for the kind invitation to chair this session, and I hope our delegates enjoy the rest of the conference, and thank you to our speakers.